Okay, good evening, everyone. This is Dr. Elena Rios. I'm President and CEO of the National Hispanic Medical Association, and we're here tonight for our 18th COVID-19 briefing session. This one is called Understanding Long COVID and the Future of Vaccinations. We have a great group of speakers, and we will show you some housekeeping right now. And I want to thank our sponsors, especially CDC, for our Vaccinate for All campaign, and AARP, who is supporting us in our educational pursuits. We want all participants to put their microphones to mute and type your questions in the Q&A box. We're using our chat box just for our staff. And then we have a short post-webinar survey that will be emailed out after the event. We'll show a Q&R code at the end, but we would like all of you to please help us with understanding what the strengths and weaknesses, if any, are for our future planning. And we do have some raffle prizes available if you complete the survey. Recording will be housed on our website, nhmamd.org, and in about a week. And also instructions to claim your continuing medical education credits. This is the learner notification for our CME. And just to say that there is one speaker who has some commercial disclaimers, and that is Dr. Morgan. You can see those on the screen, and the other speakers do not. This is part of giving CME to doctors, that we make sure that everyone knows of any disclosures. We're happy to offer those. And our first speaker with opening remarks, Yvette Peña, Vice President, Audience Strategy, Office of Diversity, Equity and Inclusion at AARP. And Yvette's been a longtime friend here in Washington, D.C. Yvette, I don't know how you do all the work you do, but we look forward to learning how you are the Energizer Bunny of AARP.
Well, I'm only as good as my team, so I have a wonderful team, and it's hard work what we do. So that's really what gives me the energy, and being on panels like this, trying to just help our Latino community move forward and stay safe. So thank you so much, Dr. Rios. And hola, everyone. Like Dr. Rios mentioned, I am Yvette Peña, Vice President of Audience Strategy in the Office of Diversity and Equity and Inclusion at AARP. Proud to be speaking here today on behalf of AARP, an organization that, like NHMA, advocates for the well-being of our Latino community. There are a few milestones that I want to talk to you about today. Some are for reason for celebration than others, but all highlight all of the advancements toward people's health. Most recently, AARP led the fight to lower drug prices. On August 16th, President Joe Biden approved the Inflation Reduction Act of 2022, which will save Americans hundreds of billions of dollars on prescription medications. For the first time ever, Medicare will be able to negotiate prices with drug companies that also put an annual $2,000 limit on how much Part D drug plan members will have to pay out of pocket for their medications, and levies tax penalties on drug makers that increase prices by more than the rate of inflation. The new law also caps the cost of Medicare-covered insulin at $35 a month and eliminates the out-of-pocket cost for most vaccines under Medicare. We all know how astronomical the cost of vital and life-saving prescriptions has become for everyone, especially our older adults. I want you all to know that AARP is on your side, fighting relentlessly in the best interest of your patients so that you can continue to provide the best care for them. I want to stop and take a moment to thank the 50,000 U.S. Hispanic physicians that NHMA represents, including each of you here on this call right now. Every day you put the health of your patients before anything else, and at no time was this more apparent than during the starting height of the COVID-19 pandemic. Just right now, Dr. Madaras told us that he just came from providing service, to patients. So gracias for all that you do. You've all showed an immeasurable amount of selflessness, compassion, bravery, knowing the risk, but not what the outcome would be. You stood on the front lines when there was no cure in sight, asking for nothing in return. You are the true nurses and healthcare professionals that help us get through the thick of it. And we owe our lives to you. But I say the start of the pandemic because we all know the truth that it's not over. We might be living a new normal, but the pandemic lingers on economically, politically, socially, and in our community and in people's lives. In May, AARP conducted a survey among nationally representative sample of adults over 50. 3 in 10 adults have had COVID at some point, and among this cohort, 76% say that they experience lingering symptoms, at least to a small extent, which has had an undeniable effect on daily life. Take employment, for example. 1/3 of those surveyed said lingering symptoms translated into the hardship on the job, as many needed to quarantine without pay to reduce their work hours. As doctors, researchers, scientists, and healthcare professionals like yourselves work on finding the root causes of treatment of long COVID, know that AARP is on your side, working to help Americans over the age of 50, including Latinos, to stay up to date on the latest news about COVID-19 with the guidance from reliable sources. Please take a look at some of the resources as I finish my remarks, which are pretty important and they're free to everyone. Please share with your communities because they can help. We've covered the pandemic extensively for over 38 million of our AARP members and their loved ones since day one. My department within the Office of Diversity, Equity, and Inclusion made it a priority to ensure that all of AARP's COVID-19 resources and information were also available in Spanish to help protect Latinos over the age of 50 and their multi-generational families. This includes sharing results of our research, updating audiences on where to get vaccinated locally, and even conducting research of our own. In May, we conducted a survey that found that 83% of those over 50 had been fully vaccinated and boosted. If we break that down, 75% of those age 65 reported being fully vaccinated and boosted, while 58% of those between age 50 and 65, still, these are great statistics. These are great statistics, and they signify something important to fight against COVID-19, that amazing things can happen when we work together for a greater good. Whether it's doctors like you who treat patients, researchers, chemists who develop vaccines and treatments, public health officials who guide us with the best intentions, and organizations like AARP who help every day to keep people informed. So each of us play a role in stopping the spread of COVID-19, and we will need to work together in the COVID next frontier, which is to find the cause and cure for the long COVID. I thank you for your time, and my hope is that this webinar informs and inspires us as we continue to deal with the COVID-19, searching for treatments and cures.
Thank you, Yvette, and thank you to AARP again for all your great work, especially with advocacy on the Hill for people over 50. And we're not old, we're just having the opportunity to work with you.
Absolutely.
So let me go to our next speaker. We are fortunate to have Dr. Cope, medical officer from the Centers for Disease Control and Prevention. And she's also a captain in the U.S. Public Health Service. And I just have to say, for all the doctors in the audience, we're very much into leadership and into leadership development. And she started her role at CDC in the Epidemic Intelligence Service, EIS, which is a very important training fellowship for physicians and others who are interested in working in our public health department. And I just have to say that through our Vaccinate for All campaign, CDC has offered us the opportunity to train 20 doctors a year over these 5 years of our grant or cooperative agreement to be able to find more doctors like Dr. Cope who are interested in working in public health and helping us. She's also been the lead for the post-COVID conditions team in the chronic viral diseases branch, Centers for Disease Control and Prevention. Dr. Cope, or Captain Cope.
All right, great. Thank you for the introduction. Really appreciate the opportunity to speak with you all this evening. We appreciate your interest in this topic. We really think it's an important one. Some have called long COVID the pandemic after the pandemic. And as we already heard, the pandemic's not over, but we're also dealing with the after effects of it. And this is going to be a major health issue for years to come. So tonight I'd like to provide an overview on long COVID, share some recent data on the prevalence of it, and in particular, what we know about long COVID among people who are Hispanic, and then finally share some resources. So my objectives tonight are to outline a framework for understanding post-COVID conditions or long COVID, describe some of the most common symptoms of long COVID and its prevalence, and discuss strategies for diagnosis and management of long COVID patients. Next slide. So to begin our discussion, we do need to address the variety of terminology that's currently in use. The term long COVID is one of the most common one used by patients and the general public, and is actually the term now being used by the Department of Health and Human Services and the White House in their communications about this topic. At CDC, we use post-COVID conditions, and this is similar to what the World Health Organization, WHO, uses. And then at NIH, they use the term post-acute sequelae of SARS-CoV-2 infection, or PASC. And while there are minor differences in what is meant by each of these terms, you will often hear them used interchangeably, and I will likely use them interchangeably this evening as well. Next slide. So post-COVID conditions refers to a wide range of physical and mental health consequences that are present 4 or more weeks after SARS-CoV-2 infection. These conditions occur for patients with severe disease and also for patients who had mild or asymptomatic acute infection. The patients can be medically complex, and a variety of processes can be occurring. We've been using a general framework for describing these processes, with the understanding that this is likely to change as we learn more, and that these groups are not mutually exclusive. So on the left, we have conditions that occur as a result of any severe illness, hospitalization, or treatment, such as post-intensive care syndrome. And then on the right, we have processes that are more specific to infection with SARS-CoV-2. And these include system-specific pathology and clinically significant symptoms with unclear pathology. Multi-organ effects following acute SARS-CoV-2 include new or newly identified neurological conditions, renal failure, diabetes, cardiovascular damage, and skin conditions. Symptoms with an unclear pathology involve a range of problems that can last for months after first being infected with SARS-CoV-2, or can even first appear weeks after the acute phase of infection has resolved. This unexplained group has features similar to myalgic encephalomyelitis chronic fatigue syndrome, or MECFS, dysautonomia, postural orthostatic tachycardia syndrome, or POTS, and other post-infectious syndromes. Next slide. So here's a list of symptoms from CDC's website on post-COVID conditions, illustrating the wide range of symptoms involving multiple body systems. And this list is certainly not exhaustive. Some of the more commonly reported symptoms include fatigue, post-exertional malaise, or symptoms that get worse after physical or mental effort, and dyspnea. Other commonly reported symptoms include cognitive impairment, which is often called brain fog, sleep disturbances, and chest pain. Next slide. The duration of post-COVID conditions can vary. Most patients appear to recover from the acute illness within about 4 weeks, and this is the reason CDC considers illness persisting beyond 4 weeks as warranting at least an initial clinical evaluation and supportive care. However, as highlighted in the figure here from the UK's coronavirus infection survey, the proportion reporting ongoing symptoms continues to decrease from 4 to 12 weeks. Improvement then slows around the 12 weeks after infection. This slowed recovery after the 12-week point is the reason the World Health Organization uses persistence beyond 12 weeks to define post-COVID conditions. Next slide. Long COVID has similarities to other previously described syndromes shown here, which also have symptoms of fatigue, cognitive dysfunction, sleep disturbances, and pain. These include post-intensive care syndrome, post-treatment Lyme disease, post-viral fatigue syndrome, and MECFS. Many cases of ME/CFS are also thought to be triggered by a viral illness. Long COVID, with its similarities to ME/CFS, might provide an opportunity to better understand both illnesses. Next slide. Patients with post-COVID conditions often present with a complex clinical picture that makes diagnosis challenging. There is no one single diagnostic test to identify patients with post-COVID conditions. In many cases, COVID-19 might not have been documented with a positive SARS-CoV-2 test. Reasons for this include lack of access to testing prior to or after the viral levels were detectable, or a false negative result. This should not exclude the clinical diagnosis of post-COVID conditions. These patients might report numerous symptoms. The number and temporal fluctuation in intensity of the symptoms reported may not fit recognizable clinical paradigms, and clinicians sometimes have difficulty just accepting that the patient reported symptoms. And this can be particularly problematic when routine tests are normal. As a result, patients can sometimes feel misunderstood and stigmatized. In addition, to date, there have been no clinical trials or evidence-based management outcomes available to guide clinicians. Next slide. So before showing some of the most recent demographic data on long COVID, I wanted to remind the audience about the disproportionate burden of COVID-19 cases among people who are Hispanic. This figure shows the percent of total COVID-19 cases by race ethnicity compared to the US population, with the COVID cases shown in red and then the overall US population in gray. And at the top, you can see the percent of COVID cases who are Hispanic is higher than the percent of people who are Hispanic in the overall US population. This indicates that post-COVID conditions might also disproportionately affect this population. Next slide. The prevalence of post-COVID conditions has varied widely, with estimates depending on the definitions used and the methods used to assess. Recent data was collected beginning in early June and most recently in late September using the US Household Pulse Survey, a survey of the US Census Bureau that shows how the coronavirus pandemic is impacting households. Questions were asked about symptoms lasting 3 months or longer and not present prior to having COVID-19. Calculations were made using the number of people who reported having COVID as the denominator. 15% of US adults who ever had COVID reported currently having long COVID. There were differences by demographics and disability status, with more females than males reporting having long COVID. Non-Hispanic Asian adults were less likely to have current long COVID compared with non-Hispanic white, non-Hispanic Black, and Hispanic. 30% of adults with a disability reported currently having long COVID, compared with 13% of adults without a disability. Next slide. The most recent phase of the Household Pulse Survey included new questions on the ability to carry out day-to-day activities due to experiencing long COVID. These new data show that 25% of all adults who are currently experiencing long COVID have significant activity limitations from long COVID. And when this is broken down by race ethnicity, we see that 37% of those with long COVID who are Hispanic or Latino, 37.8% non-Hispanic Black, and nearly 20% of non-Hispanic white, and 32% of non-Hispanic multiple race report having significant activity limitations. Next slide. So just to summarize the current data about post-COVID conditions among people who are Hispanic, people who are Hispanic have been disproportionately represented among those affected by acute COVID-19, with a recent publication showing that they have higher exposure risk and difficulty accessing healthcare. And we also saw that in the recent Household Pulse Survey, people who are Hispanic and non-Hispanic Black with long COVID have the highest percentage of those reporting long COVID with significant activity limitations. Next slide. A recent analysis conducted at CDC looked at the occurrence of 26 clinical conditions often seen after COVID. This is a study that used electronic health data, and they found that overall 38% of patients and 16% of controls experienced at least one incident condition, which translates into approximately 1 in 5 adults who might have a health condition related to their previous COVID-19 illness. This finding was even more pronounced among those aged 65 and older, with 1 in 4 having a post-COVID condition. Next slide. For those who may not have heard, under the Americans with Disabilities Act, long COVID is recognized as a physical or mental impairment that can substantially limit one or more major life activities. However, it does require an individual assessment of whether long COVID does substantially limit a major activity. This is required to determine disability. The extent of the associated disability is still unknown for long COVID, but early data does show that it might be significant. And given the size of this pandemic, even 1% of associated disability at 1 year will have a significant impact on society. Next slide. So now I'd like to share some resources that are available to learn more about long COVID and how to care for patients experiencing symptoms of long COVID. Next slide. CDC has recently updated its information for healthcare providers on evaluating and caring for patients with post-COVID conditions. A few highlights from this content include most post-COVID conditions can be diagnosed and managed by primary care. While there are specialized clinics that have been established for post-COVID conditions, these are often located in urban areas at academic medical centers, and some have long wait lists to be seen. Many patients might have access to this type of specialized care, so there is a need to empower primary care providers to take care of long COVID patients. Many post-COVID conditions may be diagnosed based on history and physical exam, and often routine tests may be normal. And because most testing might be normal, it's reasonable to consider a conservative diagnostic approach in the first 4 to 12 weeks. And that being said, if the patient has concerning signs or symptoms, an urgent workup should be done to rule out any life-threatening conditions. Symptoms persisting beyond 3 months should prompt further evaluation. And listening to and validating patients' experiences and partnering with patients to identify achievable health goals. And we also want to note, if you're not already aware, that as of October of last year, there is now an ICD-10 code for post-COVID conditions, U09.9. This is important as it will enable us to better use healthcare administration data to track post-COVID conditions. Next slide. I hope that some of you might already be familiar with CDC's Clinician Outreach and Communication Activity, or COCA calls. These provide timely information on a variety of public health topics and have been one of the primary ways CDC has informed clinicians about the latest information during the COVID pandemic. We did our first long COVID COCA call last June and have held several since then, including one in May on evaluating and supporting patients presenting with cognitive symptoms following COVID. Even if you can't attend the call live, they are recorded and the slides are also posted online. And to receive notifications about upcoming COCA calls, you can subscribe at the URL on this slide. Next slide. Another great resource for learning about long COVID is through the Long COVID and Fatiguing Illness Recovery Program webinars. This program is evaluating whether educational interventions for primary care providers through a distance learning platform improves health outcomes of patients with post-COVID conditions and other complex chronic conditions with similar symptoms. This program includes webinars that are open to anyone to attend. There's a plan for 12 webinars this year. So far, 10 of those have been completed, with the next one being held in November. Sample topic includes neurocognitive manifestations of post-acute sequelae of SARS-CoV-2. And those in attendance include clinicians, subject matter experts, patients, and caregivers. A unique aspect of this webinar series include the perspective of those living with long COVID. Next slide. One of the medical professional organizations that has been very active in addressing long COVID is the American Academy of Physical Medicine and Rehabilitation, or AAPM&R. In March 2021, they launched a multidisciplinary PASS collaborative of experts. Since the establishment of this collaborative, they have released 6 clinical guidance statements addressing assessment and treatment of several aspects of long COVID, including fatigue, breathing discomfort, cognitive symptoms, cardiovascular complications, and their most recently released include autonomic dysfunction and guidance for pediatrics. Links to these clinical guidance statements can be found at AAPM&R's website. Next slide. Finally, while we are still learning about post-COVID conditions, there are several important messages. First, it's the importance of the S on post-COVID conditions. The post-COVID clinical outcomes are complex and are not just one single entity. This makes simple case definitions impractical and presents challenges for standard disease surveillance methods. In addition, the clinical complexity precludes detailed and specific clinical guidance. Studies characterizing the different phenotypes, risk factors, and biomarkers are needed and are already ongoing. Second, due to the long duration of illness, post-COVID conditions will remain a public health concern long after the acute phase of the pandemic has ended. Increasing clinical capacity to meet the needs of patients with chronic illness following COVID is needed, and this needs to be done with a focus on assuring equity and access to care. Follow-up times for this will be measured in years, not weeks or months. Finally, it's clear that our patient advocacy community has concerns about how the government and healthcare systems are meeting their needs. We need to improve our collaboration to provide better integration of the range of services that are needed. Thank you.
Thank you, Dr. Cope. Now we're going to hear from a doctor, Chief Medical Officer for Migrant Clinicians Network, Dr. Laszlo Madaras. He's also Clinical Assistant Professor of Medicine at Penn State College of Medicine.
Thank you, Dr. Rios, and thank you all for coming tonight to participate. I know everybody's very busy these days, and I do appreciate your time. I also want to thank Dr. Cope, who just did an excellent job and made my job a little bit easier here in talking about some of the inequities in caring for the long COVID patient. She laid the groundwork very nicely here for me. So I'm going to talk a little bit about my kind of work in the hospital. As Chief Medical Officer for Migrant Clinicians Network, I work with a lot of migrant farm workers who are mostly Spanish speaking and Haitian Creole speaking. In our community in South Central Pennsylvania, I've been working with this community for the last 25 years. I'm also a part-time hospitalist physician, and over the last 3 years of this pandemic, our team has worked with over 4,500 acute COVID patients that were serious enough to be hospitalized. Out of those, we had just over 500 deaths. So in the first year and a half, it was about 1 out of every 4 to 5 patients who died in the hospital with COVID. In the last year, that has improved to a longer survival, and now it's about 1 out of every 8 patients who come into the hospital serious enough to be hospitalized who die from COVID. This still leaves a great number of people who survive, which we're thankful for, but this brings up the topic then of long COVID for those who survive hospitalization. So let me start with the first slide here. So what patients may experience, I won't go over the details again. Dr. Cope did an excellent job, but we know how to define the time span of what is acute COVID in the first 3 weeks, post-acute COVID in the following 3 weeks, and then long COVID defined as beginning 12 weeks or as 3 months after the acute infection. And there's no known endpoint. You could get long COVID much later than that. So we have a definition for the time sequence, but we don't really have an inclusive definition of long COVID.
Vito? Oh, he's back.
Did I freeze?
Yes, you did.
Oh, I'm sorry.
That's okay.
Where did I freeze? Can you?
You just mentioned the long COVID not having a good definition.
Okay, so yeah, long COVID we can define in terms of the time sequence, but not in terms of all of the various morbidities and findings that have our patients experience. So there's no known endpoint, and it can affect multiple organs, but we already discovered much of that in Dr. Cope's slides. Next slide. So some of the things I want to talk to you about are the difficulties in the Hispanic population and the Haitian Creole population regarding COVID and long COVID. So many of the things I talk about in this busy slide here are applicable to the acute COVID situation and the sequelae of long COVID. Before I do that, let me just start out with a story that will take in a lot of what this slide is talking about. So in my practice, I was an outpatient and an inpatient physician, and I have a lot of the community of Spanish speakers in my practice. They tend to gravitate to me, and many of them are in housekeeping in the hospital and also in maintenance in the hospital. And when COVID struck at the very beginning, many of our hospital staff left the hospital and worked from home. So a lot of the managers could work from home and could use Zoom platforms like we're using now to communicate and do some of their work. Our housekeeping staff and our maintenance staff could not do that. They had to show up in the hospital every day for work, cleaning the beds and picking up the trash and everything else that is so important to the function of a hospital. And again, many of these were my patients, Black and brown people, Hispanic, Haitian Creole, and other. And they could not have the luxury of being outside the hospital. And so many of them got sick with COVID during that time as well. So we were able to vaccinate many of them. But the challenges there, again, were the illness itself hit people who could not stay home and isolate. When they got sick, it was also very difficult for them to isolate at home. Many of my farm worker patients also lived in trailers and could not isolate, as they lived in 4 or 5 people in one trailer, and there was not enough space to isolate at all. The challenges also were that COVID, as we were discovering how to treat COVID and the knowledge moved forward over the months, to translate that to people who are not in a scientific world and didn't know the ways that doctors talk, would have some other sequelae that the patients themselves didn't understand what was going on, and the information kept evolving and they kept getting different information. So that was quite a challenge. And now with long COVID, similar kind of situation arises, in that as we're starting to understand all the various symptoms of long COVID, trying to explain that to people who don't have English as their first language has been a real challenge. So the fatigue that was mentioned, for example, now in long COVID is one of the major difficulties that we have with people who are in housekeeping and maintenance, as I mentioned before. And this is becoming really difficult for people with jobs that require a lot of physical labor. So the story here with the inequities include the health inequities. Again, I mentioned the housing. There's crowded housing at times, residential segregation. There's also places where there's homelessness in our community, and it's really difficult to get people who don't have good housing to be able to follow the treatment plans for COVID and also the sequelae of long COVID. There's also economics. Some of our patients don't want to admit that they have any medical issues because they're afraid that they will be then either fired or let go. And many of the people who work in our communities do not have any unemployment benefits. They only get paid when they work. And so there's a real challenge there to get people to actually answer questions about their own health. Some people are also very afraid of questionnaires and what that means, who's looking at the information. And so sometimes they don't give us the information that we would really require. So we work in our communities with trusted sources such as religious leaders and community leaders, community health workers, who then are trusted to give the important information and battle things like disinformation and misinformation. So these are some of the health inequities. I talk about structural injustices also. Some of our community have problems with drug, alcohol, tobacco use, and this makes recovering from COVID a lot worse. The social and social cultural aspects, including language difficulties and certain political instability in different parts of, this is, I'm talking globally here, will make it really difficult for patients to stay in one place to get the treatments that they need. And with long COVID, again, it's very difficult to get all of the stability that we would expect in our own country in many places. So unfortunately, this long COVID is going to be providing a lot of great stressors for people. There's anxiety about keeping your work. What happens with childcare? Many of the people I work with have their children are in school, and their source of child nutrition are the school lunches that they get. If they can't keep their child in school, they don't get the lunches, and they have to provide food and for their children at home, and maybe lose time in work. Many of the people I work with also have elderly care. They work with their grandparents who live at home, and they require care as well. So it's very challenging to have our patients who work in low income, in a language sometimes that they don't understand the information, and yet have all these different responsibilities to their children, to their parents. And then the legal system is sometimes difficult to understand. And then there's concern about immigration for some of my patients as well. So again, they're not always forthcoming with information. So basically, the challenges there are multiple. And it's going to be really important as time goes on here, because as Dr. Cope said, this long COVID is going to be with us for a long time. So it'll be very important to overcome as many of these barriers as we can over time as we try to get the handle on long COVID and the sequelae to the health of people who are most vulnerable. Next slide. So these are some of the questions about COVID and then the long COVID scenario. If you're sick, are you really sick with COVID? Is this something particularly different? Is this now, if you were sick with COVID once, will you get it again? Is this Lyme disease? Is this fatigue syndrome? Is this something else? So these are some of the challenges that we work with as clinicians to try to figure out, what is happening to somebody who once had COVID and now is sick, and what is the way we can help them. I won't go into the more details of this slide at this point. We can go on to the next one. Okay, so this is a slide that Dr. Cope had also shown. And so these are some of the conditions that I try to talk to about in terms of what long COVID can affect. And these are all things that need to be translated into Spanish and into Haitian Creole, and in a way that's understandable to somebody who does not have basic knowledge of biology or chemistry. So these are some of the challenges of, again, getting a good interpretation, and also somebody who is very familiar with the culture and a trusted source to be able to explain these conditions in a very useful way. But I won't go into that any longer than this. Again, I'm going to go to the next slide. So lack of clarity does contribute to difficult adjustments, because there's no universal definition at this time to this long COVID description that has so many different aspects to it. It is really difficult for patients to figure out on their own, do I have long COVID? Should I go to a hospital? Should I go to a clinic? We don't have very many specialized services at this time. And in fact, many of our clinicians don't know what long COVID or how much long COVID can entail in its many different forms. So both healthcare workers and family members may greet a person's symptoms with skepticism or frustration due to no clear definition and no protocols that were established. And then there's also long wait times for services, even if you live near one of the centers that can provide you with some type of care. Next slide. So caring for someone with long COVID and COVID-19, the medical course can vary considerably. Some people get very sick at the beginning and then recover and don't get long COVID. Other people have a very mild case and then get sicker with long COVID over time. And if family members try to compare their stories with each other, they may be very inconsistent. And so there may be family members who doubt that, you don't have the same thing as your cousin did. And so this is very different, or you're not really sick. Family members may also have worries about work and childcare, all of the above, like I mentioned. There are families who require caring for their children and their parents at the same time. And what happens if they get sick or their child gets sick and gets taken out of school and doesn't get the nutrition that's provided in school lunches. Again, some may feel very mildly or very severely ill, and it doesn't really translate into whether you're going to have a very serious long COVID or a milder long COVID trajectory over time. And then how to provide symptomatic relief, not knowing and not having the tests right now that can prove that you have long COVID. And then the question is, when do you go to the emergency department or to see the community health doctor? So these are the questions that my patients struggle with all the time. And does this person need to be hospitalized? Now, as a hospital doctor, I've not seen a lot of long COVID coming in to be hospitalized, with the exception of things like pulmonary embolisms and clots, which were sequelae of coagulopathies with long COVID. Those do need to be hospitalized. But many of the other symptoms are not requiring hospitalization at this time. So it's really, community doctors in federally qualified health centers would treat the long COVID patients. Next slide. And again, in the hospital while you're sick, there's compassion. Afterwards, with long COVID, there's often doubt. There's often doubt about what you really have, and are you just malingering, or or why aren't you pulling your own weight? And if you're working as a farm worker with another group of men and women who are picking apples, for example, in South Central Pennsylvania, to go and say I'm sick, I'm too sick to work, is really, really hard to admit sometimes, because you do want to pull your weight in your work, but you also don't want to lose your job if you admit that you are sick. And so there's a lot of challenges here as well, and some of the inequities of the people who work in labor-intensive jobs, and for whom fatigue really means a potential, career-ending kind of situation. Next slide. So some of the mental health burdens are also there, with the anxiety of, maybe losing your job. There's, in addition, some sleep and wake disorders that some people have, anxiety and fear related to, again, what's going to happen in the long term. How am I going to take care of my family? I need this job because I don't get paid if I don't have a job. And then there's the trauma and stress related disorders. And then some people use analgesic drugs, antidepressants, sedatives, anti-anxiety medications, and this can lead to a very bad downward trend as well. Next slide. So some of the symptoms we already talked about: brain fog, fatigue, lack of concentration, executive function decline, memory, difficulties breathing, depression, and anxiety. These are all things that make everybody suffer and make every type of job more difficult. But again, the people who are working in physical jobs this becomes often career-ending. Next slide. So the difficulties of getting medical care for long COVID conditions have been described by some of my patients as requiring a lot of work on the part of the patient or the patient's family. And the long COVID patients describe this as being, being a patient is a full-time job, and being an advocate is really working overtime. And then there's anger, frustration, and despair added to the burden of already being sick. Next slide. I'm going to finish here soon here with when does illness or injury work related? So Dr. Gobin mentioned that it's really important for people to have their illnesses documented. So if you have any injury or illness resulting from a sustained course of any occupation or employment, it could be work related. Next. And all it takes is for you to be 50%, just more than 50% sure that it is due to work. So what I ask clinicians to do is please document when a patient comes to you, especially somebody who's vulnerable to lose their job because of the long COVID potential sequelae, that they have some kind of documentation at the beginning of their illness that they had COVID, or they probably had COVID if you weren't able to do lab tests at the time. This will help them later on to get some type of disability help in case long COVID becomes so disabling that they can no longer work. Next. You can use these words, more likely than not due to work, most likely cause of the condition, but for the work, the condition would not exist. So again, these are some of the words that will be helpful to use in documenting a case that somebody had COVID and will require some additional aid later on if they get long COVID. Next slide. So please use your chart documentation, because this is really critical. Think about the patient's future needs. And if this is work related, they may get some kind of compensation, which may preserve their family unit. This is the documentation that's needed to confirm a disability. Next slide. So I think with that, I will stop. If you have any questions at the end, let me know. Migrant Producers Network has a great website, and we have our material here in comic books, accessible in Haitian Creole, Spanish, Portuguese, and French. So if you have any need for any more information, we do have our website available, and we are discussing long COVID conditions with our vulnerable populations here as well. Okay,
Great.
Thank you very much.
Great, thank you, Dr. Madaras. And let me just remind the audience, we have a lot of information here, but we'd like to clarify any questions you have. Please put your questions, type them in the Q&A box. We will have questions and answer after the last speaker. And our last speaker is Dr. Jane Morgan. She's a cardiologist and executive director of the COVID task force at the Piedmont Healthcare Corporation in Atlanta, Georgia. She's also been a contributor to CNN. And I think it's very important, Dr. Morgan, what you're going to talk about is the bivalent vaccines that are so important that we let our patients know about now, given all of the COVID experience that we've gone through. And so we welcome you and thank you very much for being here.
Thank you for the invitation. I really appreciate it, Dr. Rios. It's a pleasure really to be here at the National Hispanic Medical Association today. So thank you. Next slide. So these are my disclosures on Moderna, Novartis, randomized now, and Stairwell Chronicles. Next slide. And this is a further disclosure. I am human and I make mistakes. Next slide. So as of this month, more than 372 million doses of Pfizer's vaccine have been given right here in the United States, and almost 236 million doses of Moderna's vaccine have been given right here in the United States. This is not worldwide. This is here in the United States. Worldwide, that number is over 1 billion. Next slide. So what is a bivalent vaccine? So when we talk about bivalent, bivalent actually means two parts. And so what it's comprised of is 50% of the original formulation, that was developed against the original strain of virus that we have for this SARS-CoV-2 virus. And then 50% is the component against this Omicron family of viruses. And the idea is to give you this protection that is both broad and also very focused and narrow as well, as we currently are in this pandemic where the Omicron variants are circulating. The point is to get vaccines into arms while the variant that is affecting people is actually circulating. We've been in this pandemic now for 2.5 years, and we have been chasing variants. And so the idea now is to get these vaccines into arms with an Omicron specific formulation while Omicron is circulating and not after it has died out and perhaps we have further variants. So it's updated to better protect us against the more common variants of Omicron right now, which is the BA.4 and BA.5. We received emergency use authorization on August 31st for this vaccine, this bivalent vaccine for both Pfizer and Moderna. The studies that were submitted, people often ask me this, the studies that were submitted to the FDA were on BA.1, a sister of BA.4 and BA.5. And I'll talk about why that is important. But we did see a much better immune response to this bivalent formulation than the original monovalent booster. Monovalent really just means one single focus of that original formulation. And so the data that was submitted to the FDA for the BA.1 variant was from Moderna. They included 600 adults ages 18 and older, and Pfizer BioNTech, 600 adults ages 55 and older. Next slide. That's just the background. Let's look at the Omicron family. BA.4 and BA.5 are our single most transmissible. This is our most transmissible family of variants that we have had to date. They have a lot of immune evasive properties. And that means that our medical therapeutics have been fairly inactive against them. That includes not only our monoclonal antibody therapies, but unfortunately some of the prophylaxis therapies that we have, like Evusheld, have also been challenged under these particular variants. That is very concerning because it means that variants are changing, and each time they invade our bodies, they are learning a little more. And as they create these mutations, the mutations come together to form these variants. We could continue to be in a situation where variants continue to evolve ahead of our medical therapeutics. And that's why we're trying to get these bivalent vaccines into your arms while these variants are circulating. So of the two, BA.4 and BA.5, BA.5 is the most transmissible of the two. Currently, even though that number is 65%, when I did this slide, it's actually 62% today, and BA.4 has gone down to 11%. So I'm going to tell you why that's important. This next box, BQ1 and BQ1.1, are actually descendants of BA.5. These variants are currently circulating and are really projected to take over this number 2 spot that we have of our circulating variants. And they are actually progressing fairly rapidly. So this bivalent booster should almost certainly provide improved protection over this entire family. Right now, we see BQ1 and BQ.1.1 are now greater. That says 11%. It's actually 16% of cases in the US is continuing to move forward. So we want to really have a push to see if we can make sure people can get protected, because even though by and large, we've had fairly mild symptoms, this is a generalization, with this particular family of variants, we don't know what will come with future variants, including, it doesn't necessarily have to be worse. Mutations can also make the virus weaker. And so it could burn itself out, or we could be facing a more formidable variant. And so we would like to try to stem this tide and try to get this under control. Next slide. And so what do we have under our emergency use authorization boosters? What is approved? What are our options? We've got Moderna, bivalent booster. It is approved for everyone, children. Remember, children 6 years of age and older. Pfizer is approved for 5 years of age and older. So really every single person in our population that is 5 years of age and older has an opportunity to get this bivalent booster. Novavax, you probably haven't heard much about it. Novavax is an approved vaccine here against COVID. It is in the monovalent formulation, so it has that broad spectrum. It is not specific to Omicron. It is approved only for those 18 years of age and older as of October 19th. Mostly what we are using Novavax for is for those people who've been on the fence and have basically just refused the Pfizer and Moderna vaccines. They have refused any messenger RNA vaccines. But we have to remember this vaccine only targets the original strain. It also can only be used as a first booster shot. So you cannot use it if you've already had a booster and you're getting a second booster or a third booster. You can also use Novavax as your primary series. So if you are opposed to messenger RNA vaccines, Novavax is an option. It is given as a 2-dose vaccine, 4 weeks apart. You can get your primary series and your first booster shot under Novavax. So anyone who's already had a booster cannot opt to get this vaccine currently. So if you have already had your booster, you cannot get this vaccine. And then Johnson & Johnson is not available for booster. However, if you received a primary series with that single dose of Johnson & Johnson vaccine, you are eligible for any booster that is available, Moderna, Pfizer, or Novavax. So feel free that regardless of what vaccine you've received, you can move forward with any of these doses. Remember though, the Novavax is monovalent and not bivalent. Next slide. So if you look at the number of COVID patients that are hospitalized per million worldwide, we take a look at this. Why is this important? Well, it's important because this is a global pandemic. And when we look on this map, we can see that the curves are starting to go back up. That is not a great sign. We want these curves to continue to go down and flatten. France right now is leading with 300 per million, but we see the United Kingdom, Canada, Belgium, and we see the United States down at the bottom, right above Israel. And even though we haven't seen that turn yet, what we have learned from all five surges is what happens in Europe happens in the United States. We generally track 5 or 6 weeks behind. And what does that usually look like? We've seen it again and again and again. It starts to increase in Europe, and then it shows up in New York, and then it heads to the West Coast. We see it out in the California, and then it comes to the Southeast. We see this exact same pattern. And so we have to be concerned when we see these curves upturning now in Europe, that portends what we can anticipate here in the United States. So it's very important for us to push this bivalent vaccine and this campaign ahead, especially now as we are looking at these new variants coming up, the BQ1 and BQ1.1, and also children as we battle respiratory syncytial virus that's coming in early this year, and also flu. Next slide. So how do we get here? How do we get here? How are we 2.5 years into this pandemic and we still haven't quite put it to bed? You know, one thing to think about is that 14.8 million people have received this new bivalent booster. Sounds like a lot of people, but in the United States, that's really not. That's about 5% of everybody who's eligible. That's really a negligible number. That will never get us to where we need to be protected from these variants ahead of what we're seeing happening in Europe and what we're bracing for here in the United States. Still, we've got over 300 Americans that are still dying daily from COVID. We don't really even talk about it anymore. We've begun to accept this as our new normal, but that is really unacceptable. And so COVID is still here. And even though we've got this family of variants that that cause by and large fairly mild disease, we still see people dying. People are immunocompromised. We have premature people. We have elderly people. We have people who are on all types of cancer therapies. So we have to remember, as a society, as a fabric, all kinds of people are around us who may not survive a COVID infection. And then herd immunity. We miss so many opportunities to reach herd immunity. We closed doors, we allowed windows to close, and we continue to go from one variant to the next to the next. It was very difficult for us as a nation to follow public health measures. For public health measures to be effective, the collective have to move forward as one. And we have not been able to do that as a nation. It's been very polarized, been very divisive, and certainly science has been undermined by many social media platforms, large platforms with people with absolutely no scientific background. And certainly we've seen also other purposeful malfeasance that has undermined the voices of science and caused people to doubt. And so time and time and time again, we have missed the opportunity to reach herd immunity. Herd immunity, just as a background, is when enough people in society have protection until everybody doesn't have to have that protection. It actually comes from a term from farmers. They noticed this in their cows. When diseases came through, the cows that survived seemed to never get sick again. And then new cows that were introduced into the herd later also seemed to not get sick. So as long as the slice of society that is unimmunized or unvaccinated remains relatively small, everybody can stay healthy. That always worked in the United States, such that people, because we gave live attenuated vaccines, there were many people who could not take those vaccines because it would actually give them the disease. And so as long as that remains a very small slice, then all those people benefited from living in a society where everyone is healthy, because there was no place for disease to penetrate, and then everyone remains healthy. And so we have a lot of anti-vaxxers who say, look at me, I'm healthy, I've never gotten a vaccine. Well, it's not because they've reached some higher level of nirvana or some exalted level of higher thinking, or that they have some incredible immune system, or that they found just the right cocktails of vitamins to take. No, they remain healthy because you and I get vaccinated. And so they then don't get exposed to any of the diseases because we're not sick and we don't introduce them. Next slide. And so the CDC data, 50% of adults have not even received the first booster, let alone this bivalent booster. And then the Kaiser Family Foundation recently published that 50% of Americans haven't even heard of the bivalent boosters. So much work to be done. Next slide. 80% of America is fully vaccinated. Fully vaccinated, by definition, is 2 doses of Moderna or Pfizer, or a single dose of Johnson & Johnson. Unfortunately, that's still the definition. So for 80% of people who are fully vaccinated, 93% of those are ages 65 and older, 74% are between the ages of 18 and 64, 61% are between the ages of 12 and 17, and 32% are between the ages of 5 and 11. And so you can see, as you get younger and younger, the uptake of vaccines is less and less. Older population certainly was serious about getting vaccines early. Let's do the next slide, please. How many have a booster? And this is just one booster. You see that number drop, 66%, 65 and up, 34%, 18 to 64 years of age, and only 8% at 5 to 18 have had any type of booster. Next slide. But you see every age group drops. Let's look at California just specifically. In 2020 and 2021, the Latino residents accounted for 47% of the COVID-19 deaths, even though they only make up 40% of the state's populace. In January to July of 2022, which is this year, Latinos were only 34% of the COVID-19 deaths. So what happens? In that same time period, white deaths increased by 10%, by 12%, from 32% to 44% even though they only make up 35% of the state's population. There are a number of reasons for this. Age is certainly a factor. The majority of the older population in California and indeed in the United States is white, but also political affiliations also encourage different demographics to either step forward or step away from the vaccines. And I think we see this in, by and large, the older white population. Next slide. And so questions, if you're pregnant, if you're breastfeeding, if you're expecting a child, if you're planning, can you get this new bivalent vaccine? The answer is yes. We look at the V-Safe app, which is an app where you can upload all symptoms that you have after your vaccine, and we collate all of that information. It's well understood that primary COVID-19 vaccines and the monovalent booster shots are safe and effective for this group, and it's assumed that bivalent boosters will not be any different. Next slide. The other thing to always think about if you're pregnant is that if you are infected with COVID, the risk to your baby is greater and the risk to your health is greater than any risk of the vaccine. And just some questions that I get often: if the bivalent booster provides better protection, can I get it as my primary shot? The answer is no. The reason is it is only approved under emergency use authorization as a booster. It has not been approved for the primary series. Those trials are ongoing. I was infected with COVID-19 recently. Should I get the new bivalent booster? And when? The answer to that is it depends on the timing. If you were recently infected in the last 2 to 4 to 5 months, then most certainly you were infected with Omicron. Therefore, you have some protection currently moving forward. However, if you are more than 90 days out or 3 months, then it's time for you to get the bivalent booster. So if you were infected with COVID-19, it will depend when. Certainly, if it were a year ago, that's some other variant. You absolutely should get the booster tonight or tomorrow. If you were infected recently, however, and 90 days haven't expired, you were infected with one of the Omicron family, you are probably okay. And the recommendation is you can wait for 90 days. And also you may discover, it may turn out, we are seeing that once you get the booster, you have an even further augmented response and a better protection than even those who received the booster or those who were infected. So you've got a combination of infection and booster. Can I get the bivalent booster at the same time as my flu vaccine? Absolutely. And we encourage everyone to get both at the same sitting so you don't have to come back and forth. Should I get the same brand of bivalent booster as my other shots, or can I mix and match? You can do whatever you like. There is data, however, that shows you may have a better immune response by mixing and matching. So if you start with Moderna, you may want to switch to Pfizer. If you start with Pfizer, you may want to switch to Moderna. If you have Johnson & Johnson, you go to Moderna and Pfizer. There is data that shows mixing and matching can give you a more robust response, but you can stick with one if you like it and that's what you want, or you can mix and match. It's up to you. I am eligible for the bivalent Omicron booster. When should I get it and who cannot get it? Well, you can get it immediately. You can get it right after this webinar. If your pharmacy is open, you can absolutely get this booster. It is available. If you have not ever had any shots, this primary series, then please go and start with your original doses. That will not be bivalent, but you can certainly have an option between Moderna, Pfizer, or Novavax if you've never gotten any vaccines. Who cannot get this vaccine? Really, anybody who's had any type of allergic reaction. This is incredibly rare. Remember, this is messenger RNA. This is not egg-based or chicken-based. So allergies are very rare, but there are some components that might give you an allergy. If you've ever taken any type of laxative or stool softener and had a reaction, then you may want to check with your doctor, because the ingredients that are often found in laxatives and stool softeners, this polysorbate, is also an ingredient in these vaccines. That's probably the only contraindication, but check with your doctor. Next slide. Hi, this is Dr. Jane Morgan, and I wanted to take a moment just to talk with you about childhood vaccinations, certainly since COVID vaccines are now available for all children. This is a 60-second. And older. We want to make certain that parents have the right information. And many of us are probably not old enough to remember when common childhood diseases used to be fatal at times. And so when you think about COVID, think about adding it to all of the protections that you provide for your children in terms of vaccinations like measles, varicella. I think it froze, but
Yeah.
polio, tetanus, hepatitis. We have to begin to think of this in terms of not only how do we protect our children, but how do we protect society as well. I hope you'll take your kids in soon to get that COVID vaccine. Thanks.
Great.
Next slide. And so I do something like that. That's called my Stairwell Chronicles. I have little 60-second vignettes where I answer a specific question about COVID and all kinds of health topics. Feel free to follow me, Dr. Jane Morgan, DrJayne, Morgan, at Twitter, Instagram, YouTube. I even have a website, stairwellchronicles.com. You can access all of these. Look for a question that you have, and I'm happy to answer it. This last slide, this is the CEO of Novartis. I put this up here, working on a treatment for Lp(a), which is a type of cholesterol. But what's important about this slide is all drug companies, many of these larger companies are now working on combination drugs, just like this bivalent vaccine, to what? Improve compliance of patients. So instead of taking 5 pills, they can only take 1. They don't have to remember everything. Instead of getting 3 vaccines, they can get 1. All of the companies are now working on it, including Novartis, to try to improve your health and improve the ease with which you can get your medications. Thanks very much for inviting me today. I appreciate it.
Thank you. And thank you to all of our speakers. I just a couple questions. I know we're just about at time here, but there's one question that came from Dr. Ken Dominguez, and that's about the disability rates and the claims. I don't know if CDC is following that, and I don't know, Dr. Madaras, if you can answer, but do you think that their disability claims in the U.S. have increased post-COVID, and can we say that it's really related to COVID, given that Latinos, for example, are so many have been exposed to COVID, and we appreciate that we can project that many of the people with long COVID are going to be Latinos too, who have a lot of fear factors in language problems and access problems. So, have the COVID, have we seen, and maybe Yvette, you'd know too from AARP, have we seen disability claims go up? Can anyone answer that?
I put an answer in. I am not aware of that, but I can say that I've been part of a conversation or been, have heard discussions around that with folks from Social Security Administration. I know it is of interest, but I don't know that that data is yet available.
Okay.
The
and then
projection is for
Yes.
1 million disability claims is what we are projecting
Okay.
currently. In the
Yeah,
United
I would say it's too soon right now to have that data, because it will take a little while for people to come out. But again, as I mentioned, it's really important for our clinicians to do as clear documentation as possible, given all the limitations, that the event happened at some point where your patient did have COVID.
Yeah.
And sometimes it's really hard because a large group of farm workers come together, and that there's 3 people there who have COVID, and one has symptoms, but you didn't check that one. And it's a real disservice to that one particular farm worker who was not brave enough to come forward. And you say, we think everybody in this group had COVID, but you didn't actually document that one farm worker. And that one is going to suffer later on because your documentation was really poor for, one person. So, I should really encourage people to document your patient's symptoms early on, and that will help later on if they do get long COVID and do require that. But I think it's too early anyway.
Okay, no, but that's good to know, documentation. The other thing I wanted to ask, you mentioned a lot of symptoms, right, of the long COVID. Is there anyone in particular that's showing up more than the others?
Well, so I work in the hospital, and again, I mentioned that the coagulopathies that develop, and then DVTs and pulmonary emboli, et cetera, strokes. Some of these are being seen in the hospital. I fully document that could be related to a previous COVID infection. I don't know what the general outpatient physicians are seeing right now in terms of the other aspects of this, but certainly fatigue, and as Dr. Coben mentioned, chronic fatigue now, and fibromyalgia, and all these things that we don't really have great lab studies to confirm. These are going to be the really difficult situations to really feel out and distinguish which one of these is what's really happening.
Right. So the data in support of Dr. Madaras, the data shows that the number one reason for disability is that brain fog, and second is the sort of disorientation, which is still sort of more of the cerebral. So the reasons for disability have been much more the mental and difficulty managing your jobs, and then the physical one is with regard to sort of this chronic fatigue. And shortness of breath.
Makes sense.
Those have been the top ones as far as the data so far.
I have to ask one more question, because we are looking at our physicians and nurses and community health workers too, all our caregivers. And I know AARP is very much involved with caregiving for our elderly population. Can anyone talk about the importance of mental health of the actual caregiver, because this is like we said, it's not a disease that just comes and goes like the flu. And for all these families that in our communities that are having to deal with this, or the doctors themselves who thought, gee, when is this going to end?
Well, I'd like to do a little advertising for MCN at this point then, because we have a program in Migrant Clinicians Network called Witness to Witness that addresses exactly that. Caring for the caregivers and what happens with burnout. And we lost a great deal of a large number of our clinicians over the past few years. I don't have the exact numbers, but a lot of my staff retired, or my experienced nurses are, retiring early. So we lost a lot of clinical support within the hospital and also in our federally qualified health centers due to, I think, this kind of burnout. So we do have a program that addresses that, and our website is called Witness to Witness. And I'd recommend checking the MCN website for that. We have a psychologist who works with us there full time, and she's been busier than ever in the last several years now with that question exactly.
Yvette, anything at AARP?
Oh
with
my
all of your
gosh,
resources?
This is what we do. Absolutely. When the pandemic hit, we immediately had the AARP.org/coronavirus and then El Coronavirus. We also have extensive information on AARP.org/caregiving and AARP.org/cuidar. There's a prepared care guide on how to take care of the caregiver, because if the caregiver isn't well, how can they take care of a loved one, right? And so we have all of the resources. There's a prepared care guide in all different languages, even in Chinese, that you can find on the website. And so it's really important to take a look. There are tips, and mental health is really, really crucial to anything that a caregiver does, because again, if you're not well, your family can't be well.
And one thing that I will add before we go, since I talked about vaccines, is that those who are vaccinated, we have increasing data to show that those who are vaccinated are less likely to go on to long COVID. So think about that. The vaccine not only protects you from acute illness, it doesn't necessarily protect you from infection because of the way these variants have now developed, but it seems to provide some protection for moving forward into long COVID. So think about that as well.
Well, I'm going to thank everybody, and I know we're not going to be able to answer all the questions that we have on the screen, but let me just say that this session is going to be recorded and on our website, NHMAMD.org, in a week. I want to thank all of our great speakers. I want to thank AARP for supporting this and CDC for supporting us. And I do want to just mention, we have different programs, especially in our annual conference, which our audience may not know. We're taking it out of Washington, D.C. for the first time in about 10, 15 years. We're going to Chicago the last weekend of April. And we all are very supportive of our Vaccinate for All campaign, but we need more champions, individuals or organizations who can help spread the communication messages that you heard tonight. We need to do our part in increasing vaccinations, especially the bivalent vaccine that Dr. Morgan talked about, and to let people know about long COVID and how they should seek medical care. And if they are fearful of medical care for one reason or other, and they think they might need disability in the future, they have to get it documented by a doctor, especially in our community health centers. And we'll pass on information to everybody that was on in the audience today. And then the last thing I want to say is there another slide, Vito? We also want to thank you. And again, we have the survey. If you want to take the QR code and do the survey now, or we will send it to everybody that was on here. But the last thing I wanted to say is that the National Hispanic Medical Association and our foundation, the National Hispanic Health Foundation, it was actually our foundation, received a grant from CDC to help diversify the public health workforce of the future. And I have to say that, Dr. Cope, you mentioned the importance of long COVID as a public health problem, public health illness. And it's not just in our clinics and our hospitals, but our public health infrastructure needs to be beefed up. And we're looking for Hispanics and African Americans and others, the community health workers, to join the public health workforce. And we will be holding special meetings on how we can get more young people, especially out of college, to think about going into public health. And I'm sure that the CDC is also planning to have more public health jobs, but we are very interested in finding a diverse public health for the future workforce for all of this. Frankly, I don't think the pandemics are going to go away. And I want to thank everybody on here for all the tremendous roles that you play in your own agencies and organizations. And we look forward to working with all of you and working with the audience on helping us educate more of our communities about the importance of getting vaccines and the boosters and taking care of their community, to also echo the messages that we're all putting out on social media that, need to quiet down the disinformation and the misinformation that's out there.
Right.
So thank you all very much. And thank you to the staff, to Vito and Alma and everyone else that helped with this tonight. Thank you.
Thank you.
Thank you.
Good night.
Good night.
Buenas
Thank you.
noches.
Thank you.
Bye. Buenas noches.
Buenas noches a todos.
Yes.
Bye.
Adiós.